moving into RSI. So the 7 P's for RSI: preparation, pre-oxygenation, pre-medication, pre-intubation, pharmacy, positioning, placement of the tube, post-intubation management. Priority before intubation: resuscitate before you intubate. Brookins is big on this: resuscitate before you intubate. What happens if we intubate somebody and they've got some soft blood pressures, they're tachycardic? What's more than likely going to happen?
Arrest.
They're going to say if they're already peri-arrest when we push our drugs, more than likely after we do it, they are going to arrest. Not just from the medication itself, but once we introduce positive pressure breathing respirations, it'll actually change the thoracic pressures in the chest, which cause a drop in blood pressure. So if they're already peri-arrest prior to, then more than likely they will find their way into cardiac arrest. So run fluids. Obviously, if we had blood, that would be the way to go. Then we've got some push dose epi, get those pressures up. So next month we'll learn more when Jeremy does trauma. He's already talked to Dr. Brookins about it. Dr. Brookins is not a fan of intubation in trauma, especially any kind of exsanguination or where their pressures are low because they might be bleeding into their belly. You get them as high as you can go because they need blood. We don't carry blood. So if they're maintaining, they're mentating, or even if they can take a NPA, OPA, whatever the case is, go that route before trying to truly RSI them. Like I said, Jeremy will touch on that more. So the pharmacology, if you've noticed in our protocol, it's changed a little bit. And Jeremy just had a meeting, I believe it was last week, was it? Mm-hmm. With Springfield, Maumee, and then us. We're getting away from the the weight-based dosing for our medication. It's going to be more of a range, which I don't know if this is the updated one.
No, it still has
So this is still the old one, which it will come out. So we will actually get a dose of ketamine with a range of 100 milligrams to 200 milligrams, rather than 1 to 2 milligrams per kilo dose. It's going to be that strict, or I shouldn't say strict, that 100 to 200. Rock is going to be 100 milligram dose. Jeremy wants to get away from that weight base because, as he will tell you, I don't work at Cedar Point. I don't know how much people weigh. Wentz looks like he could be 300 pounds because
so muscular.
He's so muscular. So we could overdose you on induction agents. So, yep, once you look like you're going to get 100 of ketamine and 100 of rock. Huh? The other thing to touch on with the pharmacology is if we're RSIing somebody, we're taking their airway, we need to think about some post-intubation sedation. Because there have been studies shown that people who the sedation will wear off and now they're paralyzed for 35 to 45 minutes. It's a real trippy feeling. They've done studies. People have actually volunteered, like, hey, take me into the OR, and you can give me some rock, and I'll be part of your study. Like, we're talking PTSD, nightmares at night, because they have that feeling of I'm fully awake and now I can't move, I can't breathe. So sedation. It's when fentanyl Versed comes into play afterwards. Here, this is more of our protocol. Here's the innovations. Like I said, this will be changing to get to that actual dose range, 100 to 200, 100 milligrams. So keep an eye out for that. Protocol review, helpful tips, things to remember when intubating. Plan and prepare your medications. Assess your airway with the Heavens criteria. Has anybody ever heard of the Heavens criteria? No? We'll talk about that in a minute. have a backup and failed airway plan, whether that's, if we're intubating with the glide scope and a bougie, having that LMA, or if we think it's going to be difficult, having the scalpel out so that way we can crank if need be. Get all your equipment prepared, the head of your bed at 30 degrees. Just remember your ear to your sternal notch, kind of like the guy right behind us on the cot there. That might be a little high, but that's not a bad position for him to be in to really increase that view. Pre-oxygenate. Everybody thinks RSI, we're doing this super fast. It should honestly never take take less than 3 to 5 minutes to get everything ready to go before you actually push your medications and then stick the blade in. You can non-rebreather, 15 liters a minute. Our goal is a SpO2 of greater than 95%. If we get Meemaw that's on BiPAP, she's not doing well, leave the BiPAP on her until you're ready to tube her. Let that BiPAP help to pre-oxygenate. The other big thing that we do at Lifelight, throw a nasal cannula on there. Turn that thing up to 15 liters a minute as well. So that way when we actually push meds, they're paralyzed, they're still getting passive oxygenation with that 15 liters by the cannula. Limit your number of attempts. If you don't get it the first time or you're fumbling around, stop, pull out, check your sats, check your end tidal, ventilate if you need to, go in for another attempt. And if you have to, switch people. I know we're going to be getting a lot of students coming through here soon. If you want them to have the first crack, help them guide, work through it. And if they don't get it, all right, get out of the way. This is our Heavens criteria. Things that we can look at prior to intubation, so that way we can try to mitigate any of these circumstances. So hypoxemia, we don't want that sat less than 93% when we go to stick that blade in. Extremes of size, pediatrics are obese, anatomic challenges, whether that's trauma, mass, swelling, foreign bodies. Lieutenant, remember that code we had down there at 5757 here a few weeks ago? Josh, you were there. That guy had that giant mass in his neck. Yeah, that would fall under the anatomic challenges. Vomit, blood, fluid, exsanguination. Obviously, if they don't have enough blood circulating, they're not going to be able to oxygenate as well, and they will desat faster. And then neck. If you have somebody that's got a pumpkin right on top of their shoulders, they have no neck, no mobility, that's going to be a difficult airway. Confirming our tube placement. What's the golden standard for tube placement, Bowman?
We use supraglottics first.
But once we get that tube in, after you put your supraglottic in and you pull it out, because now we're intubating, what's your gold standard for tube placement?
Visualization.
And
tidal. And your end.
End tidal. There you go.
Long sounds.
Long sounds. Who was it? It was Christine the other day. She made the comment of lung sounds. And I'll be honest, I never thought about it. How many times when we listen to lung sounds after we intubate somebody, do we just go straight up here? Christine's like, nope, you should actually listen the basses first. How'd she say
Left
that?
to right.
Left first, then right, and then over your belly. Because if we in EMS are notorious for intubating too deep. We think that we got to shove that tube in there, as far as it'll go. And what happens? We end up right main stemming. So if you listen left first and you don't hear anything, and you look and you've got somebody that's 5'2" and they're at 26, 27 at the teeth, like, all right, that's a little deep. Let's pull that back a little bit. Rule of thumb is always 3 times the size of the tube. So if you're intubating with a size 8 ET tube, about 24 at the lip or at the teeth. If you're a size 7, roughly around 21. I've always been told, Dr. Meyer down in Lima, He was a big proponent. If you've got any of us in here, none of us should be intubated with anything less than a size 8 tube. If we're getting intubated with a size 7, like it's breathing through a straw. Size 8's bad, but always go big. And then troubleshooting our intubated patient, you have the Doppler's pneumonic, displacement, obstruction, pneumothorax, equipment failure, rigidity of chest, and stacked breaths. And those are our references. And then don't forget, resuscitate before you intubate. Any questions?